So I have always had this blank slide in my talk to acknowledge that I'm an epidemiologist, and I deal with numbers and calculating mortality rates, and just to acknowledge the people that are behind those numbers and those rates, and the loss and the grieving families that remain, and a lot of times children and partners and parents. And so just to make space for them here, and also for you all to just know that very unfortunately, I'm going to be talking about death and violence today, which I wish I had a different research topic to bring more light. But just to give you all space to do what you need to do, head off to a bar if it feels better at this point, go home, lay down in the grass, whatever you need to do. This is just a reminder to take care of yourselves, and then keep in your heart and your mind the people that we're talking about today. So I'm going to come at you with just some data just to set the background on this topic, which is maternal health and specifically maternal mortality in the United States. I'm assuming not all of you, or I don't know if any of you, anybody in the maternal health world, or well, for those of you that are not, you might be aware that we're not doing so well when it comes to maternal mortality in the United States. We've had one of the highest rates of all high-income countries on Earth for many years now, and that's really driven by this huge racial inequities. So Black women in the US experiencing mortality rates 3 to 4 times higher than white women, and really driving our high national rates relative to other countries. That has not changed in the 4 years since CDC resumed reporting of maternal mortality. So in 2018, that was the first year CDC reported our national maternal mortality rate for the first time since 2007. And since then, they've been tracking it every year. Every year, we see this big racial inequity across groups, and we see that it's increasing. So great that they've started tracking it. Great that we have national data available now. But I'm hopeful that it's brought awareness to the problem. But clearly, there more needs to be done to reverse the trend that we're just beginning to track. So this is a slide that I actually prepared for a talk I gave to the NIH to encourage them to think beyond the biomedical model. So NIH, given the new reporting, are, I think, increasingly aware of maternal mortality as an issue in this country. It's got a lot of high-profile media coverage, a lot of high-profile cases of people brought attention to the Congress to increase funding. And so when I go to the NIH to talk about how to address this, NIH, as you know, being a very biomedically focused government agency, really stressing the fact that maternal mortality is a reflection of our societal values, and that we are seeing these broad racial inequities and these increasing rates, I think, as a result of who we value in the society and who we don't. And I think that's a hard statement to say on a day like today, and thinking about our societal values and going forward. And knowing that, context matters. Every maternal death is inseparable from the context in which it occurs, and that we should think beyond biomedical and clinical research questions to really address population health and well-being, which would include pregnant people as they become pregnant. I think that so this is probably familiar to all of you public health focused people, but sort of thinking socioecologically about maternal health, which in our social context is reflecting the lived experience of pregnant people, the places that they work, the policies that shape those places as harmful or protective for health, and the opportunities that those places provide. And then, of course, the structure and functioning of our society that dictates who has the power to make policy and what policy they make, which then shapes the social context. This is just another slide to bring in one of the broader perspectives that the title of this talk sort of referred to. So we've been talking about and showing data on maternal mortality, which is obstetric causes of death. But when we think more broadly about the health and well-being of pregnant people, we can look at other causes of death that are happening at significantly greater incidences than some of those maternal causes of death, like hemorrhage and hypertension, some in blue there, compared with what we're seeing in terms of overdose, homicide, and suicide in pregnant and postpartum people, all of which have been increasing like maternal mortality since data have become available. And I should say that I'm saying all of this to in no way diminish the need for clinical research, biomedical research, and clinical interventions to prevent maternal death, and especially maternal hemorrhage, hypertension, other causes of obstetric death, which are happening far too greater frequency here. But just to sort of broaden the way that we're thinking about this issue, it's I think important to know really what's going on. So the point that I want to make with that is, we can talk about the differences in who counts and who doesn't. So CDC will only count obstetric causes of death when they're talking about reporting of maternal mortality rate. They'll talk about pregnancy-related mortality, which is counts the same people as maternal mortality, but it goes out to a year postpartum as opposed to cutting it off at that 42-day mark. Which, you can argue, I'm in no way a clinician or know anything about clinical obstetric care. But cutting something at 42 days, presumably that's when the clinical risk diminishes after birth. But I think there's an understanding of the seriousness of longer postpartum terms. And so we've started to look more at pregnancy-related mortality. Again, that's just maternal mortality cases sending out to a year. And then even broader than that is the concept of pregnancy-associated mortality, which is just death of the person who is pregnant or within the year after the end of their pregnancy due to any cause. So that includes maternal mortality, any obstetric cause of death. It also includes those other causes, homicide, suicide, overdose. So my point so I don't know if you've been in the literature to see a little back and forth with me and the CDC on this. But my point is that by, getting stuck in the weeds of how we define what what outcome rate we want to estimate and who counts and who doesn't, we're really, getting away from the point being that if we address the shared root causes of all of these things, we can really then begin to promote maternal health and safety. So some of my earlier work has sort of tried to look at some of what I think are root causes of maternal mortality. So we've looked at, that strict definition of obstetric causes of death only. We've looked at pregnancy-associated mortality, specifically a lot of work on homicide. Some of our work looked at community violence, structural racism, income inequality, these sort of broad structural societal features that underlie why we have such poor rates overall and such large inequities. And I do a lot of work on intimate partner violence and violent maternal death in particular. But we've looked at intimate partner violence as related to, increasing risk for hemorrhage and hypertension and all of the other obstetric causes of death as well. So again, if we can move that far enough upstream, we don't need to be arguing about who we should be working to prevent or what case we should be working to prevent, but rather just to promote health broadly. And then more recently, I'm thinking, how do we work on structural racism, income inequality, community violence, and intimate partner violence? And I think that's policy. I'm hoping that'll be policy. And so looking at how can we enact policy changes to address the root causes of death and poor maternal health in this country. So I'm going to talk the rest of the talk about some of the specific policy evaluation work that I've been doing. And a lot of that is at the state level. So, I think that we're all well aware that this country is starting to feel more and more like a collection of countries rather than a united group of states, because we have such glaringly different climates in terms of our political climate, our social climate, our histories, our geographic size or geographic features. And so we're really starting to see that play out, obviously, in the red and the blue states, the policies that are enacted in some states and not others, which are wildly, different, the total abortion ban versus protections to shore up abortion. And we're starting to see that play out in population health. So we have measurable differences in life expectancy across states. We have wild differences in maternal health and maternal mortality. And so my argument is that clearly policy and the state context matters. And so let's focus on that and look at how we can identify which policies are harmful and which policies are health promoting, and try to sort of bring all the states up to where we all should be. So this is just to illustrate that point visually. You can see here pregnancy-related mortality rates by state. So clearly the South not doing so well there. These are some graphs that Jackie made for me on an ongoing project we have, looking at some of those other causes of pregnancy-associated death. So a lot of variation here in terms of homicide, suicide, and drug overdose. And so, not only am I interested in doing research that is helpful for advocating for policies that will promote health, but I think the reason to do that is because of the human rights framing of health, right? So if you're taking a human rights framing, it's not only useful to have the evidence on what policies are harmful and which are helpful, but how do you take that evidence and use it to actually, ensure the right of people to health and to avoid the violation of human rights that is maternal mortality. So identifying this issue as one that requires the removal of harmful policies is really the motivation that I take in my research. So I think I talked about that. So this slide is a single slide with a lot of information that summarizes many years of work that I've done on homicide during pregnancy and postpartum. So just to summarize it all for you, and I'm sorry the text is so small, but I want to give you this much background on it because I'm going to talk about a couple of policies that we've looked at, and because this is such a serious issue and one that appears to be getting a bit worse. So again, pregnancy-associated homicide would be the homicide of a person who's pregnant or within 1 year postpartum, or 1 year from the end of their pregnancy. So we know about half of these cases are occurring postpartum. The other half, of course, death, homicide of a pregnant person. The vast majority involve intimate partner violence, so they're perpetrated by an intimate partner, and most involve firearms. And I think in terms of the cases that involve intimate partner violence, I always should asterisk that. That's where it's known what the relationship between the victim and the perpetrator is. I think that's truly an underestimate of the truth. There's a lot of cases in which the victim, there's no surviving defensive family member that might maybe know what the relationship between the victim and the perpetrator was. And so it's my feeling after doing this work that there's more involvement of intimate partner violence than is ever shown in the data that we have. And all of these cases are preventable. And I make that point because preventability is something that maternal mortality review boards debate about, which even in cases of obstetric hemorrhage, I think is an absurd task to debate the preventability of these deaths. In my mind, every single one of them is preventable. Homicide, preventable, but even things that are happening in the hospital. There's the issue on preventability is one I guess I should articulate in an op-ed, but I think it's a problematic proposition, and if we can think of every single one of these cases as preventable, maybe we can move on to more active things. So what we showed in the 2018-2019, the first 2 years of national data available, like I showed the CDC's graph on maternal mortality, we looked at homicide in those 2 years and found that the homicide rate exceeded any single obstetric cause of death. And was was a finding that got a lot of media attention. It's a really sensationalized headline. And the point I would say to journalists is that that finding has been in the literature for decades, probably. I think there's a paper from the 80s from a single hospital in Jersey that found the same thing. So it shouldn't be shocking because it's been known for so long. What's shocking is that it's still the case that homicide is still a leading cause of death in pregnant people in this country. We looked at it again in 2020 and saw a big increase. So as you all know, 2020 was a violent year. Saw increases in gun violence across the board, homicide in the general population, huge surge in gun ownership that year, and a 3.2% higher homicide rate in pregnant and postpartum people, and an increase that was larger than the increase experienced by reproductive age women who were not pregnant with postpartum. We see really high rates in adolescents. So adolescent women and girls and other people who find themselves pregnant really can be at high risk for fatal violence. It's something like a 6-fold higher rate of homicide in pregnant adolescents than in non-pregnant adolescents. We see mirroring maternal mortality, large racial inequities in homicide, again, manifestation of structural racism and racial inequities in bodily autonomy. And then the point that women who are pregnant are more likely to be killed than those who are not. Again, something that domestic violence advocates have always known. And that is really evident in now that we have national data every year. Same findings where you're looking at a homicide rate in the population who are pregnant postpartum, a homicide rate in women and girls who are not pregnant or postpartum, but are of reproductive age, and seeing, I think it's about a 16 or 20% increase in risk. So pregnancy itself is a very dangerous time for a lot of people. And I think when we think about that, it sort of helps to shape how we can intervene at a policy level, and I'll sort of get at what we're talking about in a second. So we spent a long time doing all this descriptive work. If anybody is a student in here, I highly recommend descriptive analyses. They can be really impactful. You just need some data, just run some descriptives, and they're really useful for advocates, for policymakers, just to talk about issues. I think, when I was a student, I got caught up in doing the fanciest modeling I could do and learning all these cool techniques, and I love doing that stuff. But I think the power of some descriptive work can be powerful, like literally these just mortality rates. It's FE101. So having done all of that, I wanted to move on to what do we do about this issues, and how can we address it with policy? So again, highlighting the fact here that about 80% of cases involve firearms. That used to be only around 65%. In 2020, that went up to 80%. It's remained there ever since. So really the involvement in firearms here is a key issue. And the other one is that pregnancy, again, itself is the risk factor. So if you think of guns and you think of pregnancy as risk factors, how can you prevent those two things in order to potentially save someone's life who's in a violent situation? So now I'm just going to come at you with a lot of individual research studies, and please feel free to interrupt or ask questions. I should have said that at the beginning. This is a study we did on firearm transfer laws. So these are laws that require persons who are under domestic violence restraining orders or convicted of domestic violence to transfer their gun. So just a note on nomenclature here, or language. On this issue in Louisiana, a very pro-gun state, we actually were able to get this law passed, but it wasn't without a lot of arguing about how to refer to it. So I think the initial law was a firearm relinquishment law. Then they changed it to firearm surrender law, which was like a horrible, that was not going to work at all. Firearm transfer seemed to be, palatable enough to the pro-NRA legislators that were at the table. So language really mattered here. So we call them firearm transfer laws. The paper that is like the publication on this calls it a firearm relinquishment law. Would edit that now if I could, but call it what you will. You are not allowed to own a firearm, and if you have one, you have to transfer to law enforcement or a sort of licensed gun dealer. So we looked at that law and we just evaluated it in every state from 2011 to 2019 and looked at how it impacted homicide rates, pregnancy associated homicide rates over those states in years in a difference framework. And so what we found is that, okay, so some states have a prohibited possession law that just simply say you are no longer allowed to possess a gun. And that's sort of it. And that's sort of missing the mechanistic piece. So some other states will have both the mechanistic piece and that prohibited possession law. So the mechanistic piece is you're not allowed to own the gun and you have to transfer it to law enforcement or to a gun dealer or to some other provision that they've set up. So we found that you have to have both, which makes sense. So states with both laws experienced 3.74 fewer homicides of pregnant people per 100,000 births than they would have in the houses under each law. So again, language mattered. Language mattered for us to get the law passed. And you know, I'm actually working with Dr. right now on another grant where we're doing qualitative interviews with legislators at the state of Louisiana, with pro-gun rights people, and with domestic violence advocates on this issue. And it was interesting. One of the state senator from the district that includes New Orleans said that he brings, he's the one that brings the gun control law to the Senate every year, even though he knows it's, in his words, dead on arrival. So he brought a red flag law last year that didn't stand a chance. But he says, it's about language and about introducing it and talking it. And he says, I'm bringing this now so that maybe in 5 years I can get it passed. So I thought about that a lot last night, about long game and about the next 4 years, and keep bringing it and keep talking about it. And I think that can matter to get it passed. Now, obviously mechanism mattered. Once it was passed, there had to be a way to make it effective. And that's sort of sadly what we're seeing in Louisiana is that, while we do have the required relinquishment or transfer of the firearm, it's law in the books. It's not being put into place because judges are not willing to call for the removal of a firearm. Sheriffs are not willing to take a firearm from someone who's there. So there's ways to shore up that law with provisions. And so working on the mechanism now that the law is in place is where that needs to go. I don't know what Pennsylvania's laws are. Everybody? Look that up after this time. You should know this because we are working on another national analysis of red flag laws with a similar with it. Their effectiveness on intimate partner homicide prevention. So I guess just I think it's kind of obvious why would removing firearms from a violent situation prevent homicide? They're obviously the most lethal means. And when they are brought into violent situations, they are very effective at killing. We know even research has shown that abusers who own guns inflict more severe abuse. So it might be that removal of firearms could prevent death from other means. We really difficult study to do. We tried to limit the cases of, we tried to do a firearm specific mortality rate and didn't have enough statistical power to do that. So that's just a note on my whole career has struggled with statistical power. So again, any students in here, don't let that stop you. Reviewers will complain about power, but you know what, you can still look and hope to find something that's and help those. So the other point here, so doing a lot of work on firearm getting the firearms out of a violent relationship can really help, I think, reduce the fatality of that situation. The other thing is to get the pregnancy out of the situation, because we know pregnancy can introduce a huge amount of risk for people. And so the ability to not become pregnant or to end a pregnancy when one occurs can have real implications for people's risk of experiencing fatal violence. And that's a horrific thing to say out loud, and it's a horrible sort of thing that I've spoken about a lot in the media, and to be like affiliated with that, because pregnancy is, you know, typically a great time of joy and baby showers and love and family. And it's just not the case for a lot of people in this country. And it's horrific. I don't know why I did this research. I tell my sister I'm gonna do some kind of tree studies or something. But yeah, it's just sort of checking our reality on what people are actually going through. And I think I've tried to really make that point for legislators who, especially in Louisiana, very religious, very, you know, family forward, thinking about babies and pregnancy, and that it's really not. It's not about joy. It's not always great. So this is just, again, a visual of that added risk that pregnancy confers. So we have the pregnancy rate in the pregnant population, in the maternal population, and then in the non-pregnant, postpartum, not postpartum, and reproductive age. There was a 16% gap, so 16% elevated risk in the earliest years of data. Again, when we saw a big increase in both homicide rates in 2020, it was more so for the pregnant population. So now 35% greater risk, and that 35% is total population. We see, again, in adolescent women, it's 6-fold higher risk that pregnancy confers. In Black women, it was larger, and you know, raised by age and younger Black women. So this is another place where I want to sort of broaden out our thinking on maternity and maternal health, which is like what my career, you know, I'm a maternal and child health epidemiologist. But I think that's, even that framing has been really problematic and maybe contributed to where we are today. Because we think about maternal health as just like this population of pregnant women that just dropped out of the sky and let's make sure they're healthy. But these are people who are pregnant, whether they want it to be or not, have to carry a child that they've been wanting to have and are delighted to have or didn't. And so this siloing of maternal health from abortion access has really, I think, helped to frame the anti-abortion political climate that we're in. So this is a map from that I pulled from the internet last week, but I think it would be different today, right? I think last night, I know in my home state, Arizona, there was we repealed the ban. So there's the point of light. Missouri repealed the ban. Missouri is dark red. Florida did not. And I think all the blue states that were shoring up their already open access had some success there as well. So yeah. So thinking about how do we protect maternal health? Well, let's make sure that everyone who finds themselves in a maternal health population, you know, wanted to be there, wants to be there, and can be, how do we help them have the healthiest reproduction they can? So framing, sort of broadening, you know, maternal health care, obstetric care into comprehensive reproductive health care, which includes abortion, which includes things like IVF and all of these other things that, you know, policymakers, when they were banning abortion, were thinking about, and how the various ways that people arrive at pregnancy. For some people, it's really hard and expensive and, you know, grueling IVF treatments and horrible, you know, experiences of miscarriage. For some people, it's really unwanted and they can't get an abortion. For some people, it's just great. You're just sort of typical pregnant and having a baby. It's just a spectrum of experiences. So of course, ACOG, UN, WHO, everybody affirms that abortion is a necessary component of comprehensive reproductive health care, should be available to all persons. As we know, that's not the case anymore. So this is just a summary of the evidence that I've been building to show the maternal and child health impacts of a restricted abortion environment. So we looked at intimate partner homicide rates, maternal mortality rates, infant mortality rates, and then place-based inequities and access to care. I'm going to go through these studies briefly. So, you know, as I've said many times now, pregnancy can accelerate violence in a relationship. And so looking at how would the ability to end a pregnancy relate to someone's risk of homicide. We did this paper last year looking at state trap laws. So trap laws are targeted regulations of abortion providers. This would have been prior to the Dobbs decision. These were some of the most commonly enacted abortion regulations and some of the most effective at forcing clinic closures. And these are things like requiring a specific corridor width in the facility, requiring it was some sort of structural standards for the building. None of these are in any way meant to protect patient safety. They are not necessary for patient safety. They are solely political attempts to close abortion facilities because they can't afford to renovate the building, for example, to meet the state requirements. So we sort of operationalized an index, basically just how many trap laws did the state have in effect over the 2014-2022 time period. We linked those to state level rates of intimate partner violence related homicide of reproductive aged women. Did the difference in difference. If y'all partner with economists, they can just run some difference analyses or epidemiologists. We really isolate the impact of implementing these laws. And I should say, like, most of this, actually, yeah, almost all but one of these studies are in a pre-Dobbs context, which is a shame that I can't provide you with more updated information, but it's just a sort of a caveat of the data delays. So CDC has only just 2 months ago released the 2023 natality file, and they have not released mortality yet. So we can't do the year post Dobbs look at what happened with natality and death. But what we found prior to Dobbs, I think, you know, is pretty relevant and forward looking. So what we found was that trap laws were associated with a 3% increase in intimate partner homicide in states that enacted these laws. We estimated that would have accounted for about 24 cases of homicide of pregnant people over the states that enacted these laws. So again, we know that it's pregnancy itself that can be a really dangerous stressor. Pregnant people are more likely to be killed. Pregnancy can increase violence severity. Injuries inflicted on pregnant people are more likely to be fatal than injuries inflicted on non-pregnant women. Pregnant women are more likely to die by intimate partner homicide with a firearm than non-pregnant women. To me, that's something about the ability of firearms to do their damage, you know, from a distance and not having to put their hands on somebody. And, you know, we know from a lot of qualitative work on why people seek abortions, common reason that's heard is either to end an abusive relationship or to not bring a child into a violent relationship. So another paper that actually a postdoc did working with me was to look at maternal mortality in association with abortion restrictions. So she looked at, again, this was pre-Dobbs, I think it was 2015 to 2018. She just looked at a lot of the most common restrictions that states had been enacting over the past decades, things like mandatory waiting periods, gestational age restrictions, limits on how you can pay for abortion, whether it's Medicaid or private insurance, sort of operationalized an index of severity of abortion restrictions by state, linked it to state level rates of maternal mortality, and then saw how they were related. So she found a 7% higher maternal mortality for every additional abortion restriction in effect. And then looking at the specific ones, really the prohibited use of public funds, so with Medicaid for abortion care, a 30% higher maternal mortality and 51% higher maternal mortality in states that require a licensed physician only to perform the abortion. So, you know, it was my hope that this kind of work, where these are pregnant women who are dying by obstetric causes of death, they may or may not be experiencing violence. But I think we sort of like put pregnant women on a pedestal of safety and how we should protect them all. And I thought, well, if you're talking to a legislator in Louisiana, like if you want to frame abortion restrictions as actually contributing to maternal mortality, maybe that would ring a different bell for them. Didn't seem to, but just this understanding that, you know, people bring what they bring into pregnancy, and they might know or may not know that what they bring could end up in a severe maternal morbidity. You know, if they're hypertensive and then they're out of pregnancy on top of it, if they know that their body can't handle a pregnancy, if they know that they don't have the ability to get to maternity care or pay for maternity care, their ability to control whether or not they want to remain pregnant is so important. And then, of course, you know, all of this work, we're using vital records data where we don't really know what's happening in these people's lives, but presumably could be experiencing the same risks in terms of social and economic oppression that people experiencing violence are going through. So whether it ends in a hemorrhage or whether it ends in a homicide, again, if we go far enough upstream, we don't have to end in either way. On infant mortality, this one, we looked at state gestational limit laws, and this was the law that the Dobbs decision was decided on. This was a Mississippi state law that was prohibiting abortion after 15 weeks. Supreme Court said that's fine. We looked at those gestational limit laws that were in effect prior to the decision. So prior to the decision, anything before viability would have been unconstitutional, but many states had laws on the books prohibiting abortion after about 22 weeks. They were one of the most commonly enacted restrictions, one of the most effective at closing physical abortion facility doors, clearly the most effective at making the case for overturning Roe v. Wade. So we looked at how did infant mortality rates in states change after the implementation of a gestational age limit law. And we found, in fact, a 4% increase in infant mortality, all-cause infant mortality in states that enacted a gestational limit. And I'm talking about limits at 22 weeks. As you know, now we have total bans, so 0 weeks. We have 6 weeks limits. We have mostly 12 and 15-week limits. So couple still 22 weeks, but those seem great now. So 4% increase in infant mortality, that equated to 280 excess infant deaths over the time period of this study. And I stress the point that that is the death of a live born baby. That's 280 deaths of live born infants because of an abortion. We saw a pronounced increase in mortality due to congenital anomalies. So babies that are born and don't survive very long due to an anomaly. And that tracks with the timing of those diagnoses occurring in pregnancy at a time where you've got limited or maybe no time to make the decision to not carry that baby to birth. And that decision was taken away from a lot of people, and they are forced to carry a baby to birth that then doesn't survive until its first birthday. We also saw a 4% increase in infant mortality due to prematurity, so the second leading cause of infant death, preterm birth. Again, preterm birth is really sensitive to social and economic conditions, and if you are someone who couldn't get your abortion on time because of the costs associated with travel or waiting or getting to where you need to go, you're probably carrying those same economic burdens and limitations into your maternity care that you're forced to continue and potentially experiencing a preterm birth. So, sorry to forgot you guys with all this stuff. I wish I put a YouTube video afterwards. Lastly, what we did, this last study I'll talk about I think it was such a brilliant one, and it's a doctoral student at Tulane that did it. So I should probably put her name on the slide. She's cited this for the slide, but anyway. She was sort of interested in sort of neighborhood effects, and there's been, huge body of work on neighborhood effects and neighborhood factors and how they're so important for health, and especially maternal child health. But she wanted to look at sort of linking abortion and access to abortion to a neighborhood effect. So she mapped the location of all the U.S. abortion, or of all abortion facilities in the U.S., but she was looking at a Texas law. So Texas passed Senate Bill 8 in 2001, prior to Dobbs. It was a 6-week ban, which should have been unconstitutional at the time, was unconstitutional at the time, but Texas enacted it. And it was in effect. It effectively closed the doors of a number of facilities in abortion facilities in Texas. And then she looked at post-Dobbs. So obviously Texas had a trigger ban in place. So as soon as the Dobbs decision was passed, abortion was fully banned. So she mapped all the locations of abortion facilities before and after these legislative changes. And then she characterized each neighborhood in Texas, so census tract, which in West Texas, we've got huge tracts, neighborhoods, probably not the appropriate term there, but she used census data to characterize every census tract in Texas and to see was there a relationship between the characteristic of that tract and its change in distance to care. So I'm sorry, it's just so small, but I just really loved her maps. So the blue dots are the facilities. This was the map showing the change in distance to the nearest facility for people after SB 8, so Texas Senate Bill SB 8. So obviously, if you were in cause of closure, I should have put the one there was facilities open prior. Once these facilities down the Gulf Coast closed, these people were the farthest away. They had a greater post-policy enactment, an increase in their mileage to care by 441 miles. And that was 271 to 441 miles for the people in the Houston, that's Austin area. This is how it looked post-Dobbs. So, here we see a lot of green because all the surrounding states still had open and active facilities. Post-Dobbs, all those states banned abortion. Those facilities closed down. Now we see that most of Texas has a greater than 441 mileage increase to care. So just a pretty stark visual there. This is so big. So then, like I said, she used census data to characterize these neighborhoods or census tracts. I'll clarify by distance to care. She estimated that using the census tract centroid. Right? So she's this is not an individual level analysis. She's looking at these tracts and what's the distance between the centroid of the tract to the nearest location. So she found that tracts with the highest levels of concentrated disadvantage experienced the greatest increase to care. And that was true for the SB 8 for the trigger ban post-Dobbs. It was income inequality, high income inequality neighborhoods had the greatest increase in mileage to an abortion facility. The damage, as you can see, was done in SB 8 for a lot of those communities down the tip and along the Gulf Coast. So obviously increasing distance to care is a big barrier for a lot of people because of the distance it takes to travel, the money, the time off work, the time needed for childcare. And so with this finding that it's even farther for people who are living in places that are already experiencing racial and socioeconomic oppression, to me, this just speaks to the potential exacerbation of inequities along those lines that we are likely to see. The other point to note is even in this map, you can see there are abortion facilities in some nearby states. We found that 88% of the centroids would have had the closest provider in Kansas. So they were going to Kansas, and Kansas has a 24-hour waiting period. So you're talking about a trip to Kansas where you have to go for many days. Again, just huge barriers that a lot of people are not going to be. So to conclude, I don't even know if any of this is useful anymore, but so I'm urging us all to think more broadly about population health. And sometimes that includes people who find themselves pregnant and they should be having to do. I need to articulate that argument. I think a lot about lately. But really considering research that interrogates those upstream causes, social structural policy reasons for why are we having such high rates of maternal mortality. We have excellent healthcare. We have a lot of spending on healthcare. Why should we sort of so high? And what do we do about it? Interventions. I drove Jackie Campbell, who's like the nation's preeminent scholar of violence against women. I drove her from Baton Rouge to Wallace once, and I was like, what do we do about it? And she said, interventions are really hard. They're really hard to do. Programs are hard to show that they're effective. They're hard to keep up. So that's why I moved into a policy intervention space. So I agree. I think interventions are hard, but let's do them and let's think of big policy interventions, legislation. It's all of this to I know you all are very familiar with social determinants of health. We all should be. That's been around for decades, that concept, and yet social conditions continue to worsen. So why do we have now the understanding of them and the failure to act? I think considering the implications that restrained access to abortion has in broader terms, and I hope help to increase access for people in places. I think we've seen, I think last night's results on some of the ballot measures in places that are staunchly red and staunchly abortion bans completely flipped. It's encouraging that the conversation has broadened enough to understand the implications of those kinds of policies. And then all my recommendations for actions are around, obviously taking policy evidence and doing something with it. Part of this gun grant that Jackie and I are working on is to speak to policymakers and advocates as to the relevance of research, because I've been doing this work and I've been seeing policy not go the way that I think it should go based on the evidence. And so I'm just curious what matters. And so I've been asking people, policymakers in Louisiana, what matters to you? I don't know if it's research. And obviously there's I had a previous version of this talk. I talked about the declining access to maternity care that we're also seeing. So this is like this doubly between a rock and a hard place, declining access to abortion. Take it to an abortion that you want, and then you have declining access to maternity care, so you can't get into maternity care. So it's just a perfect storm. So using policy to address that. All of these recommendations for action, I think maybe I should have deleted this slide and said, let's just be together. And then maybe I'm going to move into a canyon in Arizona. Off it very much. So thanks, everyone. A lot of talking at you today. Time for questions. Yeah, we have some time for questions. Yeah.